So the objectives are to describe and understand the clinical and utility of comorbidity opioid use disorders and pain, understand how opioid treatment, medication or opioid use disorder does not preclude the need for effective pain management, and describe and apply strategies to manage pain in patients who are on MOUD. So we'll talk briefly about prevalence. We see that there's relatively high percentages and quite a range based on these different studies that you can see of patients who have co-occurring opioid use disorder and chronic pain. So ranging from 37% up to 64%. So a significant number of people that we may encounter with both of these. And the relationship is bidirectional, but oftentimes the pain does come first. So in this analysis of over 5,000 adults with OUD spanning from 2006 to 2015, they found about 35% had no pain. About 10% had opioid use disorder first and then developed pain. About 15% had both OUD and pain at presentation. But significantly, about 40% had pain first and then developed OUD. We also know that the patients who had chronic pain before the onset of opioid use disorder have had high rates of other mental health conditions and other medical conditions. We also see that people who have opioid use disorder before the onset of pain may also have other substance use disorder, higher percentage of that, as well as rates of HIV and hepatitis C, especially if there's history of prior or current injection use. So we're going to shift to talk about acute pain management first. This is a picture that I know Dr. Bott explains that he got from the web, so was out there in public material, but this was created by a patient. You can see here titled Overwhelm, and really giving a sense of the intensity of this experience of pain. And to just start with one vignette, AN is a 45-year-old female who recently had a shoulder surgery. She has a history of OUD and was treated in the past with methadone twice. Both times when she stopped treatment, she did relapse to use. And prior to her surgery, she was using 0.5 gram twice to 3 times daily of heroin, smoking it. And then for the surgery, she was on morphine and continuous infusion, plus a PRN breakthrough medication, last having that medication 2 hours ago, and she's requesting more pain medication. She reports her pain as 9 out of 10, is tearful, her vital signs are stable. And the nurse on the floor where she is, in quote unquote, says she is drug seeking. She's already getting more pain meds than any other patient on the unit, doesn't need more. Besides, she's an addict and we don't want to worsen her addiction. So let's look at some commonly held beliefs. And, we're all hoping in this field that this is changing, shifting with time, but I think we do still have a lot of work to do, both in the medical community and beyond. Acute pain is frequently undertreated. So we see this in up to 60% in inpatient settings. And it's even more so, this is the case in patients who have substance use disorders. So addiction has in many cases been seen by healthcare professionals as primarily a social problem requiring law enforcement rather than a health problem. And this sort of this has been looked at in different analyses, and really the idea of perceived controllability kind of equates to the healthcare provider then casting blame on the patient. Oftentimes we'll see the patients as manipulative rather than seeking needed treatment. So what is the suggested approach to try to shift this? Certainly want to accept the patient's self-reported pain. But we know that these are oftentimes really complex presentations and complex histories, and pain behaviors can vary a lot. Importantly, vital signs aren't, as with this patient in that vignette who had stable vital signs, they're not a very reliable indicator of pain intensity. They certainly may vary due to it, but not always. And we want to consider that the patient may have a substance use disorder. They may also have pseudo addiction. So basically the pain is not being treated and they're needing, there's sort of an unmet need. And so, requesting more medication versus they have actual physiologic dependence, maybe taking medication as prescribed, don't have a substance use disorder, but if they were to stop, they would withdraw. So if it is required, don't withhold opioid analgesics from patients with an opioid use disorder. There's, this kind of somewhat commonly held fear that in that patient scenario came up as well, that we will worsen someone's addiction by treating with opioid pain medication. There's really no data supporting that acute pain management will worsen one's opioid use disorder. But we do see that untreated pain can certainly increase cravings and risk of a relapse. And 2 studies on, patients on methadone showed that opioid analgesia for acute pain did not increase chances of a relapse. We also know that when we're thinking about how we're treating the pain acutely, that tolerance, so if someone's on the opioid management already, that they may need higher doses of opioids due to their tolerance, and their risk of respiratory suppression may be lower, but we, certainly in an inpatient setting, fortunately can monitor them more frequently. So this is something that still needs to be considered if they're going to be having even higher doses. And remember that the opioid agonist treatment is just going to treat their opioid use disorder, but will not account for the acute pain. So the next few slides are just sort of a flow sheet of acute pain management in the ER. And just in the interest of time, I'm going to go through pretty quickly here, but you can kind of follow along. There's a colorful column on the left that sort of describes the different approaches, and it's suggested to use the column as a guide. You can always consider, if applicable, our standard non-opioid treatments, including such things as ice, immobilization, relaxation, NSAIDs if not contraindicated. And then the other alternatives to opioids or altos, such as your trigger point injection, lidocaine, gabapentinoids, and potentially for more local pain that can be localized, the source can be localized, such as rib fractures, regional nerve blocks. Continuing along this column, we can see also the potential for more advanced regional nerve blocks, which I cannot speak to at all. Probably Dr. Warwick could, if anyone's interested. Also subdissociative ketamine, so that could certainly help in acute pain. And then we've got our alpha-2 adrenergic receptor agonists, such as clonidine. But then, so managing these non-opioid techniques of pain is particularly important, I would say, in all patients, but certainly those on MOUD. Patients on MOUD, as mentioned before, have a higher opioid tolerance. If they're on naltrexone, important to remember that they should have, especially for emergency situations, and be good to carry a card, because this will take, because of its very high mu receptor binding affinity, it can be much harder to treat with most opioids if someone's especially on a long-acting naltrexone. Also, that buprenorphine, has a high binding affinity as well, so requires some strategy when applying the additional opioids. And then methadone, the thing to consider certainly with methadone as a full mu agonist is also has a very long half-life, and so certainly requires monitoring. So what about methadone in acute pain management? The recommended approach is to continue their baseline methadone after verifying the dose from the home clinic. If it's a situation like someone's coming in at 2 a.m. or that dose can't be verified, it's safer to break up the self-reported dose into 3 to 4 times a day dosing, rather than giving it all at once in the case that it is too much. And then adding in the other short-acting opioids for the breakthrough pain. Then again, if not sure what the baseline dose was, you can gradually increase the methadone dose. You would not administer buprenorphine in these cases because as that will precipitate withdrawal in someone who's taking methadone. And Patients who are unable to take their oral dose should be given IV methadone, but that's going to be reduced to a half to 2/3 and given in divided doses. And then just in terms of methadone for analgesia, this is recommended as multiple times a day dosing and can be prescribed by any clinician with a Schedule II license. However, in general, we're trying to be very cautious with prescribing methadone for pain. For OUD, this can only be prescribed through an opioid treatment program, so methadone dispensary, and typically is once a day dosing for OUD, but with people who have co-occurring pain, and in certain other situations related to their metabolism, this may be split. And then touching upon buprenorphine in acute pain management, again, we want to employ our non-opioid modalities and then adjust the buprenorphine dosing interval. So if someone's just taking it once a day, one thing you can do right off the bat is try splitting that dose. And you may temporarily increase the dose of buprenorphine, especially for acute pain. So for instance, you could consider going for someone's on a 16 milligram a day dose, increasing to 24 and splitting that to 8 milligrams 3 times a day. In the inpatient setting, consider IV buprenorphine. And then you can augment with short-acting opioids that have a high mu receptor binding affinity, such as fentanyl or Dilaudid, and certainly can consult if needed with addiction medicine. In terms of perioperative management, I feel like this is an area where things have shifted most significantly in terms of our approach. And in general, we're understanding that patients often fear mistreatment, providers may fear deception, and there has been a lack of consensus in the field. So we often, if there is still that lack of consensus, we'll base it on the preference of surgical and anesthesia teams, but really hope to have communication with them with that patient's consent in terms of pre-op. And in general, what we recommend is that buprenorphine should not be discontinued. This is a change from how we originally learned about buprenorphine years ago, but really we want to keep it on board. In some cases, clinicians may prefer to lower the dose if patients are on higher than 16 milligram doses during the perioperative period to allow kind of more receptor availability. But there's a lot of good evidence that continuing patients' dose, even at higher levels, just needs to be taken into consideration by the surgical and anesthesia teams, but can still be a very effective. And then again, so buprenorphine itself is a powerful analgesic, and so there's some synergy with the other opioids. So even if someone's on it, again, it's not going to cover their acute pain, same as with methadone. There's that tolerance to it if they're on it for OUD. But if buprenorphine's on board first and then maintained and then treating the acute pain or peri-op pain in addition. This is an article that I find really helpful, this editorial by Lemke and colleagues out of Stanford. And this has been really helpful to me when I've tried to send some increased information to surgical teams if they're kind of questioning this approach, because they give a really nice, excuse me, oh, that just went ahead on its own, a really nice outline of the approach and how to help manage patients' pain through the peri-op period while continuing their buprenorphine. Okay, and then just briefly touching upon naltrexone and acute pain management. Once again, especially if they're on long-acting, the injectable naltrexone, it's preferable for the patient to always have a card in case they're in an emergency where they can't explain that they're on it. And the suggested plan for pain management would be non-opioid analgesics, regional anesthesia if possible, but certainly if they needed the opioid medication on top of it, just need to take into account that they're on this very strong antagonist. And so the amount of the opioid required to treat their acute pain may be greater than usual, and certainly the resulting respiratory depression could be deeper and more prolonged. And so all of this was taken into account in the emergency and inpatient setting. So really they need to be monitored continuously, the opioid therapy should be provided by individuals who are trained in the use of these anesthetic medications and the potential for respiratory depression and how to intervene if needed. So a rapidly acting opioid analgesic that minimizes the duration of that potential depression is preferred. And again, we need to monitor closely. So this is just a summary slide of what we just talked about for methadone in terms of confirming the dose, and then how to proceed if not able to continue the dose. This is helpful too, this last dose letter at discharge, also for the patients and their providers. And then just let your eyes kind of go down to this bottom box here on the buprenorphine. So really we're trying to avoid stopping buprenorphine and risking someone having to restart it and risk of relapse, et cetera, and really find that it's effective medication both for pain and treating on top of it. So we want to continue our buprenorphine and use additional agonists as needed. Maximize our non-opioids and divide the buprenorphine dose if not already. So very small print here, lots of words, but these are this is kind of a summary of the peri-op considerations that I mentioned already and the approach that Lemke puts together. I will say, just looking at this, that the considerations for so we talked about buprenorphine and methadone continuing the daily dose. For naltrexone, this comes up not infrequently and also in our patients, right, who take it for alcohol use disorder, that if they have a surgery that's anticipated, elective surgery for the oral form, which again, you'll just see for alcohol use disorder. Hopefully you shouldn't see that for opioid use disorder. You'd want to discontinue at least 2 days preoperatively. And then for naltrexone, injectable naltrexone, it's every 30 days to try to discontinue that 30 days before. Certainly it's different in emergencies, but this would be preferred for elective. This is just a list of some intraoperative non-opioid pharmacologic agents. I'm not going to read this whole list, but you can see spanning from ketamine down to ibuprofen. There are lots of options. And again, we have a multimodal pain management approach, preferably. So there you have a bunch of different medications. So the opioid medications, but also the other ones that that we went over a little bit in those prior slides. But also over here in the corner, also remembering our non-medication approaches that can also be potentially useful for acute pain, so such as mindfulness, relaxation. Okay, so now in the last 7 minutes, we're going to just discuss chronic pain management. This is another slide that I think Dr. Bott found online, patient artwork, kind of depicting their experience of chronic pain and how horrible that experience can be. So some basic considerations. Remembering what we talked about earlier in terms of prevalence, that a history of opioid use disorder is the single biggest predictor of not taking prescribed opioid pain medications as prescribed. And so really important to have sort of honest, ongoing conversations with patients about that and checking in how they're doing if they are going to be on opioid pain medication. Certainly consider consulting a pain management specialist and using that multidisciplinary team approach. And then the use of non-opioid and adjunctive medications first. So ranging, again, there's your NSAIDs, SNRIs certainly can be quite beneficial. So that's your venlafaxine and duloxetine. TCAs, if not contraindicated to be on something such as nortriptyl, that those can be useful. And the gabapentin pregabalin medication certainly as well. And then remembering the use of our non-pharmacologic therapies. There's good evidence of CBT for pain, acceptance and commitment therapy. I find that in the past on a pain echo, that came up a lot as something that people wanted to both have access to, and I think has had good results. And then certainly yoga, meditation, pool therapy, acupuncture, et cetera. And then our interventional therapies, such as TENS unit, etc. Remembering our responsible opioid prescribing, there, certainly was a big push for this, which was important, and we may have swung a little too far. And so that's why the CDC more recently to take into account, patients who maybe lost treatment that was needed with the opioid medications. And we kind of tried to take in a little more nuanced approach to it, but we certainly want to be aware of patients' individual risk factors, use our screening tools for co-occurring substance use, monitor for behaviors that may not be conducive to following through with their treatment as prescribed, and really try to see those patients, get them more engaged, and work towards our sort of goals for their substance use and opioid use and chronic pain. Using our urine drug screens, PMP monitoring, and treatment agreements, again, as part of the therapeutic picture, and always prescribing naloxone with any opioid prescription. So here's one other vignette. This is for more of a chronic pain picture. This is a 55-year-old female who's presenting for treatment for substance use disorder. She has a 12-year history of chronic pain following an ATV accident and pelvic fracture. She's been gradually increasing the doses of opioids up to 300 morphine milligram equivalents per day. And she's been buying them off of the street and from different providers. She's got problems in her marriage, work, and relationships, worsening depression and anxiety. She says her pain is all over and worse than ever. And she transitioned in your clinic to buprenorphine 4 milligrams 3 times a day, which I feel like these days is a relatively low dose, especially in the time of fentanyl. And she reports improvement in her pain, happier, and that she's functioning better at work, and states, "I have my life back." So for buprenorphine and chronic pain, if chronic opiate analgesics are required for pain control, having buprenorphine may make it difficult to get analgesia from those full mu agonists. And so you might have to discontinue the buprenorphine. There's a subset of patients with chronic pain and a history of OUD who may experience a reduction of pain and misuse of the medication by taking a divided daily dosing for analgesic control. And there's also significant evidence we'll see at the end here of mitigation, the potential for mitigation of what's called opioid-induced hyperalgesia when someone's experiencing more pain actually because of their high doses of full agonists. So by transitioning to buprenorphine, we see oftentimes that improves. Here are several reasons. You can just kind of scan the list as to why buprenorphine may be a good option as a frontline analgesic. It's certainly very effective for different types of significant pain, and it's quite safe. And it tends, certainly the ceiling effect on respiratory depression, but tends to cause less cognitive impairment. And it is also effective in our elderly patients and safe in renal failure. And in general, we see withdrawal maybe milder than with full agonists. And here you can see what I was just mentioning about the conversion from a high-dose opioid, the pain experienced when someone may be experiencing that hyperalgesia. So you can see in blue, that's before they transition, the pain score, before they transition from that high and ranging anywhere from 200 all the way up to over 1,000 on their morphine equivalents, excuse me. And then the pain after in red when they transition to buprenorphine, and their pain score you can see decreases quite significantly. So for buprenorphine and chronic pain, the sublingual forms aren't approved for chronic pain, but they can be effective and they're commonly used. So certainly when someone presents with co-occurring OUD and chronic pain, and we're treating their OUD with a sublingual, that is the primary diagnosis, but we certainly may be helping their chronic pain secondary to that. The buprenorphine patch is approved for treatment of chronic pain that's severe enough to require daily around-the-clock treatment. And you can see there what the patch ranges may be up to 7 days, and then as compared to the opioid naive, when someone's taking that patch, would be a lower microgram per hour dose. And then you can certainly augment with other opioid and non-opioid analgesics. I think this is our last vignette. A 64-year-old female presents to the ED with dysuria. She's found to have advanced cervical cancer and local mets. A need for pain management has been identified. And there's concern about her 30-year history of heroin use, concerns about injection use. And she started on methadone and carefully titrated up at the OTP. She's also placed on short-acting opioids for breakthrough pain. And really the close collaboration between the OTP providers and her oncologist helped create a therapeutic effective therapy for the patient's pain. And then in some cases, patients' opioid dependence could be better treated with methadone maintenance. Certainly, it can also avoid the complications that can occur when someone may be at risk of precipitated withdrawal from buprenorphine, or in some cases, just really needing that full agonist effect and of the methadone. And with buprenorphine, perhaps they haven't been able to get the effectiveness for analgesia that they need. And then with naltrexone in chronic pain, really for patients who are on naltrexone and require opioid analgesia, this is not a good co-treatment because of that antagonist effect that naltrexone causes. And so we'd want to consider transitioning them to buprenorphine or methadone.